A very good evening to everyone, and a warm welcome to all the attendees to our fifth session of the Nomic series. I am Aarti Dara, a bioinformatician working at Cartinos Healthcare Private Limited, and I'll be your host for tonight's webinar and will also be leading the Q&A session, which will be taken up at the end. Today's esteemed speaker for the webinar is Dr. Subro Sankhadatta, a distinguished professional in the field of transfusion medicine. He is currently serving as a consultant and head of transfusion medicine at Tata Medical Center in Kolkata. He holds an MD in transfusion medicine and has made significant contributions to the field with over 50 publications in national and international index journals. Today, he will be delivering the talk on significance of red cell genotyping in clinical practice. Red cell genotyping enhances the precision of blood matching. It improves the patient's outcome and plays a vital role in managing conditions that require transfusion and in prenatal care. Before we dive into Dr. Datta's insightful presentation, I would like to take this opportunity to highlight the prestigious awards Dr. Datta has received in recognition of his remarkable contribution in the field of transfusion medicine. Dr. Datta's excellence in the field has been recognized through numerous awards, including the Young Scientist Award by the Indian Society of Transfusion Medicine. I hope I am audible. And followed by the Harold Gunson Fellowship by the International Society of Transfusion Medicine, the H.D. Shore Award by the Indian Society of Immunohematology and Blood Transfusion, and Dr. V. Puno's Silver Medal by the Society of Cardiac Anesthesiology. In addition to his clinical and research achievements, Dr. Datta played a vital role in education and resource management. He is the faculty in charge of the DNB program in transfusion medicine at Tata Medical Center, Kolkata, and serves as a resource person for the State Blood Transfusion Council, West Bengal, India. Without further ado, please join me in extending a warm welcome to Dr. Datta. And as a reminder, I would request participants to not interrupt in between the presentation, but post their questions in chat. The stage is now yours, Doctor.
Thank you, Dr. Aarti, for this kind invitation and the introduction. So I hope I am audible. So I'm sharing my screen. So good evening, everyone. And thanks to Dr. Binod and the team Carkinos for inviting me in this Nomics webinar. In the next half an hour to 45 minutes, I'm going to speak on red cell genotyping in clinical practice. And as discussed, I will be happy to take questions at the end of my session. So let's start the session. So it all starts from serology. So here we are having the conventional tube test tubes, the antiserals, pipettes, normal saline, centrifuges, and then came the much more sensitive methods like column agglutination technique and the microplate methods. And next to those methods, here comes the genotype, which is the topic of discussion for today's webinar. So genotype is the most sophisticated and precise way to predict the antigenic profile in an individual. So just a slide for serological methods, because it is still a gold standard methods. The principle is heme agglutination. Basically, we are looking for antigen antibody reactions, and methods could be conventional tube technique, column agglutination technique, or microplate based methods. It's a simple way to predict the phenotype, and it can also detect mixed population of RBCs. The limitations are it requires reliable antisera, specifically monoclonal antisera. Those are costly and often unavailable in Indian market. It is labor intensive and difficult to predict phenotype in certain clinical conditions where patients are recently transfused or patients are suffering from autoimmunohemolytic anemia where cells are coated with warm type of antibodies.
Dr. Gupta, sorry to interrupt. Would it be possible for you to share your video as well?
So I don't have the videos in the this presentation. These are
No, no,
only
no.
slides.
Your video, your
Okay,
uh,
okay. So,
visibility. Yeah.
oh,
Thank you.
so So when to perform the genotype? So we can perform the genotype in donor population as well as in patient population. In donor population, we can perform the genotyping where the antisera is not available uh, or during the mass screening for rare antigen donors or to identify ABO subgroups or D variants. In patient population, the patients who has been recently transfused within last 3 months, patient has DAT positivity, especially patients who are suffering from warm type of or mixed type of autoimmunohemolytic anemia, to help for alloantibody or autoantibody identification where serology is inconclusive, or in those patients who are on immunotherapy such as on anti-CD38 or anti-CD47 drugs. So the pros and cons of the genotyping can be automated, it can programmed for particular interpretation, and it can be high throughput. The limitations are it can only predict the antigenic profile in an individual. It's not a confirmatory, and the transfusion decision should be based on the phenotypic variability, not on the genotyping variability as per the current guideline. Now, more than one allele can be given rise to same phenotype. It can take a long time. It definitely needs resources and the cost factor. So this slide is important because scalability of genotyping in transfusion medicine depends on three factors. First, the cost of the test. Next is the speed of the reporting or turnaround time. And third is the density. Density means by doing one test, how many antigens we are actually covering. So coming to the figure B, you can see that serology is a low throughput, low density testing method. So as the PCR, but DNA array or whole exome sequencings are the high throughput, high dense method. Coming to the C figure, so you can see the drastic differences between the cost per sample and cost per antigen analysis if you see the different platforms. And look at the serology. So the cost per antigen is huge compared to the cost per sample because of the rarity and the manufacturing cost of monoclonal antibodies. So if you see the microarray or targeted NGS, the cost per antigen and cost per samples are quite close. Now coming to the workflow of this genotyping, it starts from sample collection, then DNA extraction by manual method or automated, whichever platform you are having in your lab, followed by estimating the DNA concentration and the purity, followed by RBC genotyping using the available platforms. And if you want to store the DNA, you can keep the DNA at -20 degrees Celsius for prolonged storage. The samples should be analyzed within 72 hours of collection, and it should be preferably collected after 24 hours of last transfusion to avoid the WBC interference from donor side. So this is a classical PCR-based testing platform. You can see the ladders, which is actually the reference frame, and you can see the different base pairs. And depending on the reference scale and the internal control, you can actually, internal control is for the validation of the run, and presence or absence of a particular band is actually suggestive of presence or absence of antigens. So if you see the left column, so the 720 base pair, Duffy A and Duffy B both are present. So the individual is Duffy A positive and Duffy B positive. Followed by KID A is present, but KID B band is absent. So the phenotype is KID A positive and KID B negative. So it is a KID A homozygous. Celano and the Kel both were present. And for the RH, the right side of picture, you can see the phenotype is R1, which is actually capital C, small c, capital D, capital E, small e, all are present. There are certain other microarray based testing platforms. These are bead chip or blood chip. Two companies are manufacturing this platform, and they are using these steps: amplification, followed by hybridization, followed by labeling, and finally the data acquisition and analysis. So the overall time period or the turnaround time is 4 hours, and it is a high throughput system. This is the interpretation of the result. So you can see this is actually the primers used during the testing. This is actually the genotyping result. And finally, we can predict the phenotype. So coming to the what is called serological matching and what is called the molecular matching for transfusion. Suppose the left-hand side, a recipient is serologically typed as capital C positive, but actually he possesses a C variant. So depending on the serological results, we are transfusing the individual with capital C positive units. But this particular individual may develop anti-capital C alloantibody followed by transfusion because this variant C has not been detected. But in the right hand side, if we apply genotyping, we can predict the variant C in this particular individual, and depending on the result, we can transfuse this individual with capital C negative unit, and there will be no possibility of anti-capital C formation. So this is the basic of serological matching and molecular matching. Coming to first case, a 61-year-old female diagnosed with rheumatoid arthritis and anemia for last 13 years, on occasional packed red cell transfusion for last 7 years, currently on oral prednisolone, presented with fatigue, breathlessness, generalized swelling. Iron deficiency and megaloblastic anemias were ruled out during routine investigations. Admitted with hemoglobin of 5.1 gram per dl with profound reticulocytosis and elevated LDH. But unconjugated bilirubin levels are within normal limits. So this particular picture is suggestive of hemolysis. On physical examination, the patient was tachypneic, the tachycardia was there, along with shortness of breath, and SpO2 at room air, it was 86%, and the patient was put on oxygen at 2 liters per minute, and SpO2 increased to 96%. So during serological testing, the blood group was found as B positive. No blood group discrepancy was identified. DAT and autocontrol were negative, but IAT was positive at 3-cell panel. Antibody identification was performed and suggestive of multiple alloantibodies, possibility of anti-small c, anti-capital E, anti-kid A, and anti-CW. The phenotyping could not be confirmed because of recent history of transfusion. So a series of alloadsorption and elution tests were performed to differentiate between the multiple alloantibodies as the patient required urgent transfusion. Parallelly, a molecular blood group typing request has been raised. So during the alloadsorption study, the plasma was absorbed with small c negative, kid A positive, and capital E negative cells, that is called R1 cells. The adsorbed plasma showed anti-small c antibody, whereas the elute, which is actually from adsorbed cell, suggestive of anti-kid A antibody. In another aliquot, the plasma was adsorbed with R2 cells with kid A negative red cells, and the elute from adsorbed cells showed pattern of anti-small c antibody, whereas the adsorbed plasma showed the anti-kid A antibody pattern. So why we actually raise the request for red cell genotyping in this case? Serology could be sufficient, but as this patient was suffering from rheumatoid arthritis, which is a known causative factor for alloantibody formation, and patient is a responder, so patient could form other antibodies on the top of the already pre-existing alloantibodies. So we have to predict the actual phenotype, and phenotype match should be given to avoid further alloantibody formation. Since the patient was recently transfused, blood group genotyping was performed for the prediction of RBC phenotype. The DNA extraction was done. The PCR method was followed using the RBC ready gene verify kit, which can detect 20 clinically significant antigens. And actually, it corroborates with the findings from serology. So this is actually the result of the genotyping. You can see the genotyping, by genotyping, we can predict the phenotype, and the patient phenotype was capital E negative. So it was recommended to transfuse E antigen negative red cell to avoid further formation of anti-E antibody. As this patient already had anti-small c alloantibody, so the small c antigen negative blood should be transfused. The KL antigen was negative, so it was recommended to transfuse with KL antigen negative red cell along with the KID antigen negative red cells because of anti-KID antibody. So the patient was transfused with 3 units of cross-match compatible small c negative, capital E negative, KIL negative, and KID A negative PRBC. All transfusions were uneventful. Post-transfusion hemoglobin was 10 gram per DL, and patient was discharged with a special blood group ID card suggesting of all this extended phenotype. So actually, in transfusion-dependent patient, the facility of blood group genotyping is an extremely useful tool, as it can predict the phenotype of the patient and guide the appropriate transfusion management to prevent further alloimmunization. Coming to the case 2. So an 8-year-old male child with primary diagnosis of ALL planned for stem cell transplant. Patient was receiving multiple transfusions for last 1 year. During pre-transplant workup, the DAT or the direct antiglobulin test was found to be positive. So here is the picture of direct antiglobulin test, and you can see the patient cells were coated with IgG type of antibody along with the complement C3d. The IAT was found to be positive. IAT means the indirect antiglobulin test. Anti-KID A antibody was identified. Elution study from the DAT positive cells also suggestive of anti-KID A antibody. Here is the picture. You can see, and the titer of the antibody was 4. Now, is it an autoantibody, auto-KID A, or allo-KID A? So for that, we need the genotyping. So the KID antigen system, a little bit on the KID antigen system. It is a glycoprotein group consists of 3 antigens, KID1, 2, and 3. It develops early in the gestational period, encodes by a particular gene, and the locus of the gene is on chromosome 18. It is under the urea transporter gene family, and KID glycoprotein has 389 amino acids with a 10 membrane spanning domains and with 11 exons. So it is the picture of the KID antigen, and you can see the location of KID A antigen and KID B antigen. So KID antibodies are usually IgG type of antibodies, and these are mostly complement binding. It can exhibit 2 typical phenomena. One is called the evanescence or vanishing phenomenon, and other is called the doses phenomenon. Commonly cause the hemolytic transfusion reaction. Anti-KID A is far more common than anti-KID B, and previously identified antibodies, if any, should be checked before each transfusion because of the vanishing property. So it is the doses effect. So if KID A is present on both the chromosome, it can express as double dose and can give a strong reaction. Whereas if it can present with at a heterozygous state, so the single dose of KID A expression along with the KID B could give you a low strength reaction. Similarly, that is true for the KID B. And this is the picture of the evanescence. So following the first exposure, the antibody can be detected, and after some times, it's the vanishing effect or antibody falls below the level of detection, but upon re-exposure, again the anamnestic response happen and the antibody levels comes at a level of detection and can cause the hemolytic transfusion reaction. So coming to the case 2, so the KID antigen was found to be positive. So the patient has anti-KID antibody suggestive of autoantibody, and the patient should always receive KID A antigen negative red cell unit for transfusion. So autoantibodies with KID specificities are rare but associated with autoimmunohemolytic anemia has been reported. And as with other blood groups, KID autoantibodies may have mimicking specificity. For this particular patient, KID A antigen negative blood should be transfused based on the molecular blood typing result. So the KID A antigen negative unit was cross-matched. It was found compatible and patient was safely transfused. Coming to the case 3. A 68-year-old male with transplant ineligible multiple myeloma planned for anti-CD38 treatment, which is an immunotherapy. Patient was receiving multiple transfusion for last 3 years. The DAT was positive. Serological typing was not possible for the red cell antigens. Cross-match would be incompatible because of anti-CD38 interference. Genotyping was performed to predict the extended phenotype. The goal is to transfuse with phenotype matched red cells to prevent alloimmunization. Now, those who are not very much acquainted with the anti-CD38 effect, anti-CD38 is a monoclonal antibody used for treatment in multiple myeloma cases. It can uh, destroy the cancer cells by these mechanisms, but red cells are also having some amount of CD38. So anti-CD38 present in the serum can bind to the CD38 present in the donor cells, and the cross match would be incompatible. So this is actually the protocol for red cell genotyping in anti-CD38 treatment. So according to the the ABB, so the transfusion, if the transfusion is less than 3 months and the DAT is positive, then the genotyping should be done to predict the phenotype in these patients. So we performed the genotyping in this case. So finally, the genotyping before or after starting the anti-CD38 therapy could be an effective way to improve the transfusion outcome by giving phenotype match unit for transfusion. Coming to the case 4, a 2-year-old boy admitted with pre-BALL. The patient was receiving chemotherapy in accordance with the UK-ALL 2011 protocol. During the pre-transfusion workup, RHD typing discrepancy was detected. He was typed as RHD positive at an external facility but found as RHD negative at our center. Both the parents were RHD positive. To rule out the possibility of loss of RHD heterozygosity on chromosome 1p, which might be associated with acute leukemia, samples were collected from the child and parents for RHD genotyping to confirm the RHD status. As well as the RHD zygosity testing was performed by PCR-based method using the different kit, which is called the ZygoFirst kit. Upon PCR analysis, it was noted the samples from proband for the child was detected solely within the hybrid boxes at 940 and 1525 base pairs, signify the absence of RSD gene or the D deletion. So the group is confirmed as D negative. In contrast, samples from parents exhibited PCR product presence in both hybrid and upstream boxes, signify RSD heterozygosity. So this is the principle of ZygoFirst. So if the person is D positive, then only upstream box will give the result. If person is heterozygous, then upstream and hybrid box both will give the result. And if the case is of RSD deletion, then only products from hybrid box could be visible. So this is the picture of proband and the parents. So you can see the 1 and 3. These are the 1 is the hybrid box and 2 is the hybrid box. And in the right side box, you can see the serial number 1 is the ladder. 3 and 5 are the hybrid box. So in the proband, only product could be visible in the hybrid box. So the proband is true D negative. Whereas the right side, you can see the product in the hybrid box as well as in the upstream box. So both the parents are RHD heterozygous. So finally, the genotyping is an effective way to confirm blood grouping in RHD discrepant cases. So why we are testing the zygosity? Establishing RHD zygosity in India, this is a paper from SGPGI where at least 25% of D positive Indians are found to be heterozygous at the RHD gene. So what is the implication? The clinical implication is that determining the parental genotyping is key to assess the risk for complication. So if the father test D positive, the paternal gene copy number or zygosity should be determined. And if the father is homozygous for the D gene, all the children will be D antigen positive. and careful monitoring during the pregnancy should be done by frequent ultrasonography testing the peak systolic velocity of the middle cerebral artery, etc. And if the father is heterozygous, then fetus has a less chance or half the chance of the previous one of being unaffected. So coming to the case 5. So a 43-year-old nulliparous female was admitted with a left ovarian mass. Her hemoglobin was 10 gram per dl with normal platelet count and coagulation profile. There was no history of previous blood transfusion, nor had her blood grouping been determined before. During the pre-transfusion workup, blood group discrepancy was detected. The patient was typed as AB positive in forward grouping, but the serum grouping showed agglutination 2+ with the B cells. This is the picture. So you can see the forward grouping is showing the AB positive, whereas reverse grouping, we are getting the extra reaction with the B cells. The test has been repeated using the conventional tube method after prolonged incubation at room temperature for 15 minutes. And here is the result. You can see the result of forward typing where extra reaction has been found with anti-H lectin, but anti-A1 lectin is showing no reaction, where extra reaction has been observed with A1 cells along with the B cells. So we are searching the literature. In 1975, Race and Sanger, which called that those cells which reacts weakly with anti-B but strongly with anti-AB and anti-H are categorized as B3. And following these two articles, we found one entity. So it is called A2B3, which is actually showing the similar picture. And this is from the cis-AB genotype. So finally, the phenotype basis on the serological testing was designated as A2B3. So suspecting this as a case of cis-AB based on the literature, so NGS panel was done and for analysis at a referral center rather. So the ABO gene analysis was done and it was found to be a cis-AB. So it was a first report from cis-AB in Indian subcontinent showing A2B3 phenotype where a single cis-AB allele encompassing the two variants which are known to cause the cis-AB, but these variants are present on a single allele. And transfusion requirement was managed based on the serological results. So type O red cells and type AB plasma were transfused during the OT. And this case was reported also. Coming to the case 6. So a 76-year-old male with multiple myeloma was admitted with progressive anemia. He had received multiple transfusion at a local hospital since last 3 months due to his persistently low hemoglobin level. His historical blood group was O positive. During the pre-transfusion workup, anti-D and anti-capital E antibodies were detected. Considering presence of anti-D antibodies in a D positive individual, the blood group genotyping using PCR method was performed to rule out auto anti-D. So PCR results come from the presence of D gene, could not rule out auto anti-D. D variant analysis was performed using NGS, and it was this is the result. So it was a case of allo anti-D in an individual carrying D variant, which is actually the del32 phenotype, and it has also been reported. So coming to the D variant in Indian scenario, you can see the 4 studies, and most of the studies are done at NIH Mumbai under the aegis of ICMR. So you can see the D variant frequency in Indian population Here also in our center, we are getting the results close to the Mistra et al. So not very much in our population and not a significant problem in Indian population as per the available data. So weekly 150 allele, which is actually a novel allele, which is called Indian variant of WIGD. It is basically the 12 base pair duplication at intron 3, but it has been identified as the most commonly prevalent allele in Indian population causing WIGD, but the immunogenicity is unknown. So yet to be discovered if it is immunogenic or not. It can form anti-D on receiving the D positive units, or it can form the anti-D after transfusing this particular unit to a D negative patient. So this is yet to be discovered. Coming to the last case, a 31-year-old male first time whole blood donor. Donor gave a history of previous blood transfusion 10 years ago. No other comorbidities were present. Historical blood group was ARSD positive. During blood grouping, discrepancy was observed in reverse typing. As well as during the donor antibody screening, we found that the 3-cell as well as 11-cell, all cells were showing the pan-reactive reactions with the negative autocontrol and negative DAT. So this is a result of blood grouping. So forward grouping is showing the A positive group, whereas the reverse grouping, you can see the reaction with A1 cells, B cells, and O cells. And the available family members were screened considering the presence of high frequency antigens, and no abnormality was found in the current family members. So a donor was subsequently found to have the P null phenotype, and his plasma contained the anti-PP1 PK, which is a high frequency clinically significant antibody. And 3 sets of P null cells were compatible with donor's plasma, and cells from the donor's ABO compatible sisters were found to be incompatible with the donor's plasma. So on sequencing, the A4GALT intron 1 polymorphism associated with P1, P2 expression revealed the donor to be homozygous for a particular allele, and this particular allele is associated with the P null phenotype and production of anti-PP1 PK in the donor. The donor was registered as a rare group donor in the International Rare Donor Panel. So coming to the Rare Blood Donor Registry, last year we published this paper in the Frontiers of Genetics, and we actually proposed a possible roadmap to have a rare blood group registry in Indian population. It starts from need for rare blood arises at a local blood center. Obviously, the blood will not be available locally. So the direct email can be sent to the Indian Rare Donor Registry, and from IRDR, and they can contact the regional center. Regional center can verify the request and call the donor from the registry, and the donor blood can be collected and transported to the mother hospital for transfusion. So this is a possible roadmap. So what is the actual state in India? So ICMR is going to launch the rare blood group registry soon, probably this year or the next year. And this is the available rare phenotype under the ICMR available for the Indian population. So this is a data from 2022. Probably they have found much more units at present. So you can see the distribution of different rare phenotypes registered with consent to donate. So the last slide will be on limitations and the future scope. So the first limitation is the epigenetic influences on the human blood group genes. So genotype versus phenotype discordance. So this discordance could be due to some intronic influences or some other epigenetic influences. The function of abioglycosyl transferase cannot be predicted with 100% accuracy from DNA sequencing. So abiogenotyping is far more cumbersome compared to the other antigenic profiling. And a single mutation anywhere in the A or B allele can result in an inactive transferase, a group O phenotype. So according to the American Society of Immunogenetics, abiogenotyping cannot be used independently to direct transfusion decision. Transfusion decision should be done based on the serological results for ABO blood group system. Well-characterized DNA reference reagents are needed to ensure quality and accuracy of the Rh genotyping that can cover most of the discordant Rh alleles. Recently, a paper has been published from NIH US, and they are actually characterizing the DNA reference reagent for Rh genotype. And it is also important to ensure the quality of the testing by introducing the proficiency testing for laboratories which are establishing or using the blood group genotyping facility. And last but not the least, the cost reduction and collaboration are the keys for widespread use. Thank you.
Thank you, Doctor, for this insightful presentation. And for this remarkable presentation, I would like the participants to post their questions or ask them directly. But before we take that up, the genetic analysis for RBC antigens or RBC genotyping can be offered at Karkinos, and if interested, people can reach out to us at lab@Karkinos. Thank you. And now we can take up the questions. Give me a moment. Dr. Datta, can you please stop sharing your slides so that we can interact with the audience? Yes, thank you so much. Yeah, so the first question that we have in the chat is, after more blood transfusions for CML and AML patients, the blood group antigens will have more variations in the blood. If yes, can you please explain?
So following the CML, the blood group antigenic variation can be seen in CML, AML, or MDS cases. There are multiple mechanisms for this particular effect. So in suppose in CML, so there is a translocation between the 9 chromosome and the Philadelphia chromosome. The 9q is actually is a location for ABO gene. So during the translocation, there could be possible interference in the ABO expression. That is a one mechanism. Second mechanism is the some post-translational modification could be there due to the DNA methylation. So especially in MDS cases. So following administering the agents like decitabine, which are demethylating. So then this particular blood group discrepancy could be resolved. Or when the patients are going to the remission, then you can get that original blood group that is reappearing in the circulation. So there are multiple mechanisms and there are literature available. You can go through that literature. So these two mechanisms are most commonly seen mechanism.
Interesting. Thank you, Doctor. The next question that we have with us is, do you present null phenotypes of the Duffy system? And if so, do you study the mutation of the cat box?
Yes, so it is a good question. So the Duffy system is a complicated one. So in the current kit that we have in our laboratory, It can identify the Duffy A, Duffy B, the GATA mutation, that Duffy null phenotype, as well as the Duffy X. So the Duffy X is actually responsible for low expression of Duffy B antigens. And so these four profiles are available in our PCR kit. But of course, if you want to go into the deep of Duffy system, you have to go to the some more sophisticated platforms. If you have NGS, then you can actually do the sequencing of the Duffy gene and you can actually identify the Duffy phenotype. But PCR-based test, there are some limitations to predict the Duffy phenotypes.
Yes. And I
Yeah.
hope that has been answered. Yeah, please go ahead, Dr. Bala.
Yes, Dr. Sarvo, very thank you. Thanks for the beautiful presentation. I have one doubt. How do we differentiate auto-antibody and allo-antibody in an D positive patient? Thanks.
So the D positive patient, if the suppose the patient is a D positive, then and you are getting a reaction showing the pattern of anti-D. So it could be due to the auto anti-D or it could be the allo anti-D. First, you have to identify that it is D or not, it is the LW or not. So for that, you have to treat the serum with the DTT treated cells. So if the reaction persists, then it is true D. Then if you want to distinguish between the allo anti-D and auto anti-D, you have to do the D variant analysis in that particular individual. So if any D variant was identified, then the patient, this particular case could be due to the allo anti-D. And if no such D variant is being identified after uh, D variant analysis, then it could be due to auto anti-D. I think it is clear to you.
Yes, yes, Dr. Sarva. Thank you.
Okay, thank you for answering. The next question that we have is, what is the turnaround time for RBC genotype?
So
Are you doing? Yes, that is the first part. Yeah, please go ahead.
So the turnaround time in our lab is 72 hours for PCR based assay. So I don't know the other laboratories, but in our center it is 72 hours.
Okay. The second part of that question is, are you doing genotypes for all autoimmune hemolytic cases? Would you
Not,
would like to know more about autoimmune hemolytic anemia match 2?
so I can share our brief experiences by does predicting the phenotyping in autoimmune immunohemolytic anemia cases. We are actually performing this RBC genotyping in those warm type of autoantibodies or warm type of autoimmune hemolytic anemia cases or mixed type cases who are recently being transfused and whose DCT, this DCT is positive, and the patients who are having some serologically inconclusive results, we are getting different strength in during the antibody identification. Possibly, we are suspecting that some allo antibodies are there, but we are not sure that whether these allo antibodies are present or not. So for those cases, we are doing the RBC genotyping, and currently we have performed around 20 cases of warm AIHA as well as the in mixed AIHA. I think and the results are excellent. Based on the genotyping results, we actually transfuse those patients with the phenotype match blood, and on follow-up, no patient had developed any further allo antibodies.
Okay, let's take up this next one. Is the red cell genotyping have the issue of anti-sera availability in Indian transfusion medicine setup? because to identify rare blood groups when commercial antisera are unavailable.
Yes, of course. So that is one of the indications of doing red cell genotyping in donor population, because most of the rare antivirals are not available and we don't have the storage system or cryopreserved rare group cells in our laboratory where we can detect the serum with the rare aliquots. So yes, of course, the red cell genotype could be a game changer for this particular rare blood group identification in donor population.
Yes, Dr.
Unmuted.
Sarva, I have one more question.
Yes.
Dr. Sarva, in a multiply transfused patient, how do we differentiate patient own red cell genotyping versus donor red cells?
Pardon? Just
In
repeat.
the genotyping of multiply transfused patient,
Mhm.
how does the genotyping differentiate patient own red cells and the donor red cells?
Okay, so the actually genotyping in an individual is done from the WBC. So it is not the red cells. So red cells are not having the nucleus. So it is not actually. So suppose a patient has received a RBC from a donor. So the WBC could persist up to 24 hours. That's why I told that 24 hours duration should be there from the last transfusion. So within 24 hours, that WBC could be destroyed in the circulation. So, and it is done from a buccal mucosa or from the WBC, is the buffy coat layer. So it is no interference from the donor cells.
Yes, thank you, Dr. Sarva.
And the
In
next
case of
is there a
cases,
role of Yeah. So the next question is there a role of genotyping in drug-induced autoimmune hemolytic anemia?
Drug-induced autoimmune hemolytic anemia, yes, of course, you can do the genotyping to predict the phenotype, and then transfusion could be done based on the phenotyping result. But drug-induced immunohemolytic anemia, if you stop the drug, administering the drug, that particular drug which is causing this problem, then within 48 to 72 hours, you could solve the problem. So I think blood group genotyping could be done. Of course, it can be done, but it is not an absolute indication in drug-induced immunohemolytic anemia.
Next question is after allogenic transplant, if mixed chimerism and requiring workup, how would you genotype?
So in the is a good question. So in the allogenic transplant, so in our hospital we have a protocol to phenotype all the donors as well as recipient during the pre-transplant workup, so that during the mixed chimerism or during the switching of the blood group, we can identify the change in the rare blood group, and that change by observing that change or identifying that change, we can confirm that blood group switching has been happened or not. So we have not applied blood group genotyping in the post-transplant patient, but of course there is some indication in certain cases like sickle cell anemia cases where alloimmunization is far more common rather than malignancy. So we are not dealing with the benign cases. So centers who are actually dealing with the transplant in sickle cell disease could perform this particular genotyping in mixed cell chimerism during the post-transplant period.
One of the attendees has a question: what would be the cost for genotyping, and would that involve genotyping for all minor blood groups as well?
No, I think that has to be corrected. So the blood group genotyping is done based on in our center, it is based on the kit. So our kit actually covers the 20 clinically significant blood group antigens. So it is not covering the other rare blood groups, not the D variants, not the ABO subgroups. So we are charging a patient around 8,000 rupees for a test. But this particular test is only for RH, extended RH system, KL, KID, Duffy, MNS, and all those clinically significant, but not for the ABO type, because in my last slide, I showed you that ABO genotyping could be cumbersome because there are multiple factors, and one you can get a genotyping impression that the patient the individual blood group is A or B, but phenotypically you can get as a O group. So the decision of transfusion should be based on the phenotypic result, because the patient is having anti-A and anti-B antibody in the plasma. So if you transfuse the patient based on the genotyping result, it could lead to a acute hemolytic transfusion reaction. So it is not recommended to transfuse the ABO blood group based on the genotyping result. Rather, the transfusion decision should be based on the antibody level present in the recipient plasma.
Thank you, doctor. And the last question for the day is there any issue in genotyping because of recent transfused RBCs?
No, recent transfusion RBC will not have any effect, because as I discussed, it is done from the WBC. So recently transfused RBC will not have any effect on genotyping.
On this note, thank you, Dr. Datta, for your precious time to enlighten us on the significance of red cell genotyping in clinical practice. Again, we are open to collaborating on RBC genotyping and applications in patient care, and interested clinicians could reach out to us at lab@carkinos.in. With that, we will conclude today's session. Thank you again, Dr. Datta, for sharing your knowledge and insights with us.
Thank you.
I would also like to extend my sincere gratitude to all the thank you. I would also like to extend my sincere gratitude to all the attendees for their active participation. I trust that this was an interesting presentation for everyone, and our next webinar featuring Dr. Chepsi discussing inherited bone marrow failure syndrome is scheduled for 8th of June. We hope to see you there. Thank you so much.
Thank you.
And this video will be available on YouTube channel in next 4 to 5 days. So do share and let us know with your feedback. How was it? Thank you.